All right, I think we will go ahead and get started. So let me just welcome you all to the fourth module in our planned six-part series that we're calling The Business of Medicine. Thank you for making time on this June evening to join us. I know the weather's getting nicer and the days are getting longer and such, so it's not lost on us that you would commit some time here. Topic for this evening is how healthcare provider executives see the world and how that impacts physician compensation and pressures. And just as a reminder, we record this meeting so that it can be posted online so that other WAFP members have the opportunity to watch it if they are not with us in person. So agenda for tonight, just a high-level overview, some intro comments similar to ones that I've made with each of the previous sessions. We'll talk a little bit about kind of a brief review of modules 1 through 3 and some of the highlights that set the stage for our conversation this evening. We'll talk about the evolving perspective of healthcare executive, so what that looked like 20 years ago, what it likely will look like 20 years from now, and then what the present state is, along with some of the sort of difficulties and challenges that healthcare executives face. We'll talk a bit about how this impacts employed family physician contracts. So tie some of this back to what is written in contract language for many employed family physicians. We'll talk a little bit about what family docs should remember, conclude with a summary, and then, as we always do, we will end with a question and answer period. And just as a reminder, you probably all know this, but the first 3 modules in this series are posted online on the WAFP.net website. All right, let's go ahead and get started. So in terms of intro comments, a reminder that the goal of the Business of Medicine series in 2 words is really simple. This is about physician empowerment. And so the theory or the principle behind this is that with additional knowledge and understanding, we're hoping that family physicians will feel empowered to regain a sense of autonomy and control, which they can then use to improve patient care and also increase their own personal professional satisfaction. So again, that is the overarching goal of this entire series. It's not to teach economics or finance or anything like that. It's intended to create a framework for how medicine operates behind the scenes, and that knowledge creates power so that folks can have a renewed sense of autonomy and control over what their professional careers look like and how they're able to take care of the patients that we all serve. Just as a reminder, this series is put on by the WAFP Professional Affairs Committee. So myself and Jordan are co-chairs, and then Alyssa and Lynn are really the brains behind the operation. So thanks to the other 3 for joining us with each of these calls and for helping to facilitate this entire series. And if there's anybody on the call who's not a WAFP member, I've been fortunate over the last couple of years just to get more involved in the WAFP. It is a amazingly dedicated group of individuals, not just the physicians that are part of it, but also the staff, which shares a similar passion to support family medicine, really with the intention of supporting patients all across Washington State. So if you're not already engaged or aren't already a member, I would strongly encourage you to consider that. So. And then just as a reminder, throughout the presentation tonight, you are welcome to enter questions into the group chat, and then Jordan will facilitate the question and answer period at the end. If you would like your question to remain confidential or you to remain anonymous, just send that question directly to Jordan, and then he'll bring it up, protecting your anonymity at the end of the presentation. We always talk about conflicts of interest or disclosures. I have no conflicts of interest as it pertains to this subject, but I do have strong opinions, and I think those do come through these presentations. I've said this a couple times before, but just as a reminder, this is one perspective on this topic. I've thought in preparing these sessions that you could have 10 different folks present this material, and they do it in 10 different ways, and they would all probably be equally valid and accurate. So this is just one perspective based on kind of my own personal journey and personal experiences. So returning to our simplified model of healthcare, the focus today is around provider organizations. specifically executives that run these organizations and have decision-making authority, and then the frontline physicians practicing as it pertains to physician contracts, how those contracts are constructed, what the pressures and incentives and asks are of those physicians. So I think you all remember this model. We've got the provider organizations. Those are the groups that specifically provide healthcare. So physicians groups, hospitals, et cetera. We've got the insurance companies in the top right, or the payer organizations. So that would include governmental payers like CMS and state Medicaid. And then at the bottom there is patients. So I think of this as kind of the 3 Ps. And as you can see, there's interactions back and forth across these different different groups. So focus today is really on provider organizations. I'll call them just healthcare organizations throughout the presentation, but that's really what we're focused on. And I shared a little bit about my personal journey when in the first module in this series. I'm a family physician up in Bellingham. Have practiced with an organization called Family Care Network for 15 years. And for the last 5 years, I've served as the president and CEO of Family Care Network. I still get to practice clinically, but more than half of my work now is kind of the administrative front. So this topic is near and dear to my heart. It's the world that I kind of live in and day out. Family Care Network is a unique organization because we're just family medicine and we're totally independent. So we don't have some of the challenges that larger healthcare organizations and multi-specialty groups have. But this is the world that I kind of navigate day in and day out. So let's do a brief review of modules 1 through 3, and we'll use this to set the stage for the conversation. So our first module was around healthcare companies and how they measure and define success. And you remember we used this image of this sort of spectrum of defining success. And at one end was sort of profits, or you can think about that as the business aspect of the work we do. And at the other end was patients and patient care. And I think we're sometimes inclined to say that certain healthcare organizations that we're familiar with are all about the profits or all about the patients. But hopefully I made a reasonable case that pretty much every healthcare organization is kind of a little bit of both. And really the question is, when push comes to shove, what do they prioritize? Is it really patient care, or is it sort of the business profit aspect of the work that they do? I will tell you, my experience in many healthcare organizations is that executives think of the patient care aspect as belonging to the providers or to the physicians or clinicians, but the business aspect as really belonging to the executive team and the administrative function. So as we talk tonight, it'll become clear that the focus here is not really on direct clinical care, but it's more on the business aspect of medicine and how healthcare executives think about that. Our second session was sort of tracing the journey to healthcare, going from kind of small and local, often independent, most frequently physician-owned and physician-led, to massive, large-scale businesses with large monopolies, regional organizations, statewide organizations, national organizations, healthcare organizations in some instances. And we talked through all the sort of promises of consolidation, but the realities of developing monopoly power. And so, again, I would call out here that we're going to talk a little bit about what the world looked like 20 years ago and what it'll look like 20 years in the future. Healthcare looked different 20 years ago, and one of the ways it was different is there was much less consolidation than there is today. So what that means for healthcare executives is they're often dealing with much larger organizations, oftentimes organizations where they don't really even have the opportunity to meet frontline clinicians or visit all the different hospitals or clinical sites, and that comes with its own set of challenges. And then our third module was all about the evolution of payment models. And we, again, talked about fee for service, and then we talked about sort of a general movement to this concept of value-based care. And this picture, you may recall, was from the Making Care Primary, the new CMS innovative program focused on primary care. And this was the track 3. Making Care Primary has 3 tracks. This was the track 3 sort of payment algorithm. And if you recall, at the bottom, there was a primary care cap. So that's a monthly per member per month payment. They refer to it as the prospective primary care payment. There were carve-outs, things paid above and beyond cap that will be paid in a fee-for-service approach. And there was an enhanced services payment for higher risk patients, so sicker patients. There was additional funding to support their care. And then there were these performance incentive measures as well that were around preventive care, chronic disease management, and utilization. And I was trying to make the case that contracting has gotten progressively more complex with these layered contracts that have varied reasons why money comes in, varied incentives and such, to try to align provider behavior. So again, that as we get into kind of how does a healthcare executive think about this, these are some of the components. So in summary, healthcare executives, they're juggling patients versus profits, that is running a sustainable business while still hopefully providing good care to patients, running massive healthcare organizations, and dealing with evolving payment models. So again, that's kind of the groundwork. Let's get into the weeds a little bit here. So we're going to start with describing kind of this evolving perspective of a healthcare executive. So what did the world look like 20 years ago for a healthcare executive? So if that red dot is present time, we go back 20 years ago, healthcare was smaller, healthcare was often local, healthcare was very often physician-led. I think the size and locality of healthcare actually matters quite significantly. It is hard to lead and manage groups of people when you can't even be in the same room or in some instances the same state as them. So, when hospitals were all local community-based hospitals, the executive team could simply walk the floors and see the physicians and see the nurses and see the other staff members and have a real presence. That's the way things used to be. Harder to do that as healthcare has consolidated over time. And the world at that time was really a fee-for-service world. And you all remember what that world looks like. That fee-for-service model, every CPT code that a provider enters has work RVU or has RVUs attached to it. Work RVUs are a subcomponent of that. And then there is a negotiated conversion factor, and you multiply the RVUs by the conversion factor, and that is the dollar amount payment to the organization. So vast majority of reimbursement and revenue to these healthcare organizations was through that fee-for-service model and fee-for-service approach. And so what does that result in? Well, revenue is really driven by RVU generation. And I would call out that there were no limits on volume. And what I mean by that is, if you were a primary care provider and you saw a patient on Monday and saw him again on Tuesday and saw him again on Wednesday, each day you would submit a new claim and new CPT codes, and you would continue to be paid each day for additional work. So again, the more work we can do, in theory, the more revenue we can generate. There really weren't incentives around cost effectiveness. So again, this is a model that just rewards doing more. Fee-for-service sometimes referred to as a volume-based approach to payment. So not really incentivized to save costs, really incentivized to simply provide more care. And there were fewer measurables. So measurable quality or measuring patient experience, measuring patient outcomes, much fewer of those. I don't want to say that they didn't exist at all, but it wasn't sort of common language in healthcare to focus on those things. And so if you have a situation where you're really focused on RVU generation as the definition of success, what does that amount to? It amounts to a few things that some of us that have been around for a while would remember. So first is heavy investment in high RVU generating services. And so I think you've all seen this, where a large healthcare organization would spend large sums of money on things that didn't necessarily make sense. I finished my residency program a little less than 20 years ago. I did residency down in Southern California. My third year, I was chief resident, and our hospital built a massive, fancy cardiovascular institute with crazy fancy cath labs, and they built a joint replacement center as well. Fancy, super high cost, tens of millions of dollars invested in these. And I remember very vividly going to the CEO of the hospital and saying, gosh, you are spending a lot of money on these things. It seems like what the community could really need or use is more family physicians. And he looked me dead in the eye and he said, there is no money in family medicine. And that was the justification for why they were spending all this money on these essentially cardiac and surgical procedures that generated or had high RVUs attached to them. The whole concept here was we were going to drive additional revenue into the hospital. Specialists given preferential treatment. I think that's obvious why specialists often through procedural work can generate more RVUs in a given interval of time than family docs who kind of nickel and dime their way through it. Preferential treatment, I think, took lots of forms in the history, and probably those who have been around longer than me can tell good stories. But I do remember certain specialties having designated parking spots right by the front door, and they were not the family docs that got the great parking spots to get into the hospital. And obviously, when it came to reimbursement and negotiation and how the hospital administration or healthcare administration would sort of bow to the needs and preferences of specialists, I think those that have been around a while will remember that. And then family medicine was viewed simply as a tool to feed higher RVU generating services. And so I started into medicine 22, 23 years ago, starting medical school. And a common phrase at the time was that primary care providers were gatekeepers. Some of you remember that. That's a terrible term, but basically, and I actually don't know in hindsight, was that a marketing term by healthcare organizations to say, go see your primary doc and they will open the gate for you to have all these other services across the organization? It's not a bad marketing strategy if your goal is to drive utilization and drive more RVU production. But again, family medicine wasn't viewed as something that necessarily could completely comprehensively manage care, but really just a gatekeeper to get you access to other things. And so again, this is kind of the fee-for-service world. If you've been around for a while, some of those things probably resonate as having been true. And so high-cost initiatives were really easy to justify if they would generate large RVU. So again, talked about the Joint Replacement Center and the Cardiovascular Institute. But think about huge hospital expansions where new wings are built. Think about hospitals that's, I don't hear this phrase as much, but trying to develop centers of excellence. So we're going to be a cancer center of excellence, or we're going to be this or that. Always seemed just like marketing terms to me, but money was spent on, fancy buildings and providing really fancy service and amazing levels of customer service and such, all built around getting more volume and more RVUs through the door. So again, that is the world as it existed in a somewhat oversimplified way, but the world that it existed 20 years ago. I would say from a healthcare perspective or a healthcare executive perspective, that's not a super hard game to play. Again, your single goal is just to generate more RVUs, and you do all the things we've talked about because that will drive RVUs over time. As long as you can continue to increase RVU production, managing expenses, running organizations from a lean perspective, those aren't really concerns or considerations because you can just sort of keep the gravy train flowing. And so when people say things like healthcare in the United States is way too expensive and has been for a long period of time, again, these are the incentives that drive that behavior. So that was 20 years ago. Let's move on to what the world might look like 20 years from now for a healthcare executive. So again, present time, moving forward 20 years. Healthcare has changed a lot in the interim and likely will continue to change. So continued consolidation, continued kind of big business. So massive regional or national and sometimes publicly traded or private equity funded healthcare or venture capital funded healthcare companies. So again, this is a different world. Consolidation is going to continue. You hear about this all the time in the news, even just locally here. Interestingly, the state legislature is trying to put some caps, and even nationally, they're trying to put some restrictions on consolidation in healthcare because they've figured out that it really doesn't amount to better patient care or more cost-effective care, but that's not going to change in the immediate near future. So what's the world going to look like 20 years from now? It's really going to be a value-based care world. We've talked a little bit about that, but let's talk about specifically kind of what that looks like and then what that means. So value-based care is often capitated payment with some level of risk adjustment. So instead of paying you for more volume and seeing a patient Monday, Tuesday, Wednesday, Thursday, and Friday, we're going to pay you a per member per month amount, and you are going to provide really good cost-effective care to that patient. Risk adjustment, HCC scoring and such, that's not going to go away anytime soon. I think you all know that we're transitioning from V24 to V28 on the HCC model, so there will be changes over the coming years. But I haven't talked to anybody who thinks that risk adjustment is going to disappear. HCC scoring, I think, as you all know, is not perfect, but it is a way in theory to try to divert more resources to sicker patients. Second component is quality. So this is measured. This has been the case for a while. It will increasingly be measured, reported, even reported publicly, which is kind of an interesting phenomenon. I think some of you have seen the community, I think it's called the community checkup that WHA puts out, sort of reporting quality performance across a whole wide variety of measures and across healthcare organizations in Washington State. And then clearly quality will continue to be incentivized from a contractual basis. Cost effectiveness is closely monitored with downside financial risk for overutilization. I think we talked a little bit about this in terms of how payment models have changed, but again, it's no longer kind of a volume based. It's about providing the right care at the right time to the right person in the most cost effective way. So sending every patient to a specialist, sending every patient to the Joint Replacement Institute or the Cardiovascular Institute is not appropriate, and utilization is tracked and monitored And again, there will be downside risk for providing downside financial risk for providing too much care and spending too much money on care of patients. And then last, patient experience is tracked, reported, and rewarded. We talked a little bit about that last time. I don't see that going away at any point in the near future. So in summary, this is a model where you have to have highly effective primary care to succeed, right? It's not really going to be our specialist colleagues or our hospitalist colleagues that are going to manage all of this stuff. It's going to be highly effective primary care providers. Family physicians is the perfect example of that. And I think 20 years from now, that is fully understood across the healthcare organization that we need to invest in primary care. We need to have high quality primary care. We need to have team-based care. We need to not overwhelm our primary care providers so that they can meet all these sort of necessary prerequisites to provide that value-based care. So organizations will need to run lean, be focused on high quality, cost-effective care and an outstanding patient experience. So again, I think 20 years from now, that is the definition of success for a healthcare company. So talked about the past view, talked about kind of the future view from a healthcare executive perspective. What about the present state? So here we are, present state right in the middle. Again, 20 years backwards, 20 years forward. 20 years ago, it was a fee-for-service world. 20 years from now, it's a full value-based care world. And so again, just kind of to reiterate what I said, that fee-for-service world built on a single purpose, support RVU generation. It leads to very expensive and often highly inefficient care, but cost is not a primary concern. This is a world where hospitals are valued, procedures are valued, specialists are valued. That's really the focus of how the whole system is built. It's built around volume and it's built around RVUs. And so that is the world that current healthcare executives have inherited. And we've built these massive systems to support that, right? These huge hospital buildings, these facilities that require massive resources to staff, whether that's imaging centers, MRI machines are not cheap to continue to run. And so the whole model has been built around high cost to support high volume. But that is nothing like what this future world will look like. In the future with value-based care, we've got lean organizations. They're focusing on quality and cost effectiveness. Care is much more focused on patients and patient goals and patient-centered care than being focused on specialists and procedures in hospitals. And it's recognized that high-functioning primary care is not a gatekeeper to the rest of healthcare. It is healthcare. It is value-based care. And I think I made that statement in the last module that when you hear the term value-based care, you really should think family medicine. That's what family medicine is. And so what you can see here is where we were and where we are going are worlds apart in how you would build an organization, everything from how you would kind of build the physical resources of an organization to how you would staff that organization to what services you would provide to what providers you would hire, radically different in these two worlds. And so the challenge for healthcare executives is to bridge this. Again, where we're at currently is kind of somewhere in the middle. We haven't totally gotten rid of fee for service. Probably not surprisingly, many large healthcare entities, particularly hospitals, are very hesitant to move away from fee for service because their entire model, again, from how they built their hospitals to how they staff them and such, was built around the fee for service world. But they know they're kind of being forced slowly to move into this value-based care world, which again feels like an entirely different game to play. That being said, don't feel too bad for your healthcare executives. Many are absurdly well compensated. And I just threw in there, you can look it up. You probably all know that nonprofits have public reporting requirements. So you can actually Google the annual compensation of most executives in nonprofit healthcare companies. It is astounding. I can tell you in our region, we have one healthcare CEO who makes $5 million per year. It's a mind-boggling amount, especially considering how much it costs to get care at that facility. So again, that's the challenge that healthcare executives face. Let's keep moving forward. So how healthcare executives are navigating both this kind of fee-for-service and value-based care world directly affects family docs and the contracts and the components in those contracts. So this is very relevant for employed family docs. Again, I should put the caveat that I've never personally been an employed family doc. So in Family Care Network, the family docs are the owners. And so it's a different story than in many other organizations. But I just want to walk through a family doc contract, and think about what might appear in that contract in the context of this historical fee-for-service world, but this value-based care world that we are clearly moving towards. So I'm gonna throw up a few statements that a healthcare executive might make, and then show how those might translate into what's actually listed in these contracts. So first, coming out of the fee-for-service world, we're going to need more money to fund our transformation to value-based care. So great, we need more money. And so what does that translate into? Family doc, we're going to need you to see more patients. When you see more patients, you generate more work RVUs. That'll generate more revenue for us because we're still partially living in this fee-for-service world. Then when we have that additional revenue, we can figure out what that bridge is to value-based care. So see more patients. But at the same time, patient experience really matters now. And so we want you to ensure that you make patients happy. So we want you to cycle them through much more quickly. We want you to see more of them, but we want you to ensure that you build a really good relationship with each of them and that they're all very, very happy with the care they receive. And we're going to be paid now on cap with risk adjustment. So it's not really enough just to see more patients. We actually need you to take on larger panels because in a capitated model, remember, you're paid per attributed member per month. So we really need more attributed members. So we need our family docs to take on larger and larger panels. I was at a conference a few weeks ago and I heard the term mega panel for the first time, and they were talking about the national healthcare shortage. And then one solution is a mega panel. And I thought, how in the world is that going to work? And in addition to larger panels, we need you to capture HCC codes. We can't have you do that by longer appointments because we still need you to see more patients and generate more work RVUs to fund our transition to value-based care. But it's really important that we capture those codes. So we probably won't provide you any additional coding resources to do that, but we need you to capture those codes, and we may actually pay you based on how sick your patients are. And then next, the healthcare executive says, we have to keep paying for our expensive infrastructure and services. So let's be sure that we're referring to our specialists. Let's be sure we're ordering more MRIs. Remember, we've got that imaging center that costs a lot of money to get off the ground. So let's be sure we're facilitating kind of business and volume to those internal services within our organization. But at the same time, we need to control total costs because that's what matters in a value-based care world, right? So we really need to manage utilization. So we got to keep funding the services that we have, but we have to manage total cost and manage utilization. The way I've seen that played out in many organizations is they say, you can refer, but you have to refer internally. So we're going to manage utilization by not letting you refer outside of our organization, but we're actually going to kind of explicitly or more often implicitly encourage you to refer more patients to internal specialists and order more tests and more MRIs and such. And then finally, quality is going to be publicly reported. So we also, on top of all of this, need you to perform on quality and all the standard preventive care measures, chronic disease management measures and such that we're being scored on. And so lots of different components in here. I think it's really clear looking through this that these are contradictory. And the final statement is, and be sure to join our wellness program. We sure as heck can't afford you to be burned out. There's a shortage of you all. So again, this is a crazy making world when you think about why many family docs feel taken advantage of, devalued, feel a sense of loss of control and autonomy. And now across the country, I think you all know physicians are starting to form unions to fight back against these insane demands that come from large healthcare organizations. So again, the point here is simply to call out, because healthcare executives and healthcare organizations are navigating between these two very contradictory worlds of fee-for-service and value-based care, they really put a bunch of that weight on their providers, particularly their primary care providers, family docs, pediatricians, internists, and such, to try to live in both these worlds at the same time, and they don't align, right? Some of these things are completely contradictory, and again, I imagine it's a hugely crazy making place for a family doc to try to navigate. So let's move on. We're quickly coming to the end here. So what family docs should remember. So as is often seemed like is the case with these presentations, I feel like I'm sort of saying bad news, bad news, bad news, but there is a silver lining to this. So a couple specific things to remember. First, you are in short supply as a family doc. So there's a nationwide shortage of primary care clinicians. Current estimate, latest one I heard, is that the US will be greater than 100,000 primary care providers short by 2023. I also heard another astounding statistic in the last couple of weeks. Medicare age population in the United States is currently 67 million people, and by 2030 it will increase to 90 million people. That is an increase of 100,000 patients per week that will be aging into Medicare. And that's actually the total growth of the Medicare population. So there'll be a number that pass away each week, but net 100,000 patients per week. And so you think, who's managing all of these patients? I mean, 100,000 new Medicare patients every week. So again, clearly there's a massive nationwide shortage of primary care providers. You're all familiar with the sort of supply-demand model. You're in short supply. It's worth internalizing that and understanding that. Second component, your services are critical to fixing healthcare. So value-based care doesn't work without highly effective primary care. That should be abundantly obvious from everything I've said to this point. You provide high-quality, cost-effective care while creating an exceptional patient experience. And so another way to frame this is you are in very high demand. So basic economics, short supply, high demand, that drives prices up. What that should translate to is driving up of salaries and compensation for family medicine providers in the future. Next comment, your value likely far exceeds your compensation. So even in a fee-for-service model, family docs can often generate $500,000 to $1 million in revenue for their organizations. I don't know how common knowledge is about the amount of dollars family docs generate for their organizations, but it is an astoundingly large figure. And Family Care Network, this data is sort of very freely shared across the organization. And so we can see, I mean, we have providers, a number who generate $800,000, $900,000 a year in revenue that comes into the organization. And that, again, we're sort of partially in the fee-for-service model. That number probably grows in a value-based care model. So when you think about how much you're paid relative to how much revenue you generate for the organization, again, it all sort of comes down to how the organization values you, how they recognize your contribution. It's not just a financial contribution, obviously, it goes beyond that, but highly effective, reasonably efficient family docs are income generators for large organizations. And so as it pertains to your compensation, that should be recognized and understood. Next one is locally and nationally, more resources are moving towards primary care. We talked a little bit about this last time in the last session, right? So making care primary, Washington is one of 8 states for that initial pilot, is really focused on diverting way more resources back to primary care. We know at the state government level, a couple of years ago, a bill was signed encouraging or pushing reimbursement to primary care up to 12%, or setting a target at that 12% of all healthcare dollars will be spent in primary care. Unfortunately, in that bill, there was no deadline for when that needs to happen, but currently primary care spend in Washington state sits about 5.1%. So it's a pretty substantial increase if we could get that up to 12%. We know on the national level in 2021, CMS reweighted the RVUs attached to E&M codes to give those docs that use E&M codes a pretty massive boost. That's particularly relevant, obviously, to primary care providers. And then we know January of this year, that new G code went into effect, G2211, which provides additional reimbursement to providers who serve as the focal point for a patient's care moving forward. That describes being a primary care provider. And so family docs should be using that code very, very frequently. And again, it just adds additional reimbursement, additional funds flowing back towards primary care. So I think the message has finally been understood at a national and statewide and local level that a solution to healthcare is to divert more resources to primary care and let them do the magic that they do of providing that high quality, cost-effective care. And then the last one is you may have more job options than you realize. So again, low supply, high demand, massive overall value contribution means that most healthcare organizations are always hiring family physicians. And so really, you could probably go almost anywhere. Obviously, sometimes that entails moving, and that is not feasible for everybody. But again, you can go work anywhere as a family doc. I think many of you know this. And you can even consider starting your own practice, a direct primary care practice or a more traditional model. I will call out that some of the feedback we've had from this session is we'd like to learn more about what it might look like to start your own practice. So again, I think just understanding that you have options and that you have leverage. Ultimate leverage, of course, is a willingness to walk away. That's true in any type of negotiation or contractual agreement. But you as family docs have about as good job security as you can possibly have. So take home message here, understand the leverage you have and feel empowered to take control of your career. All right, that's pretty much takes us to the end. We made really good time today walking through this. So hopefully I was not speaking too quickly. Let's, on one slide, just summarize the key points from this session, and then we'll move into the question and answer period. So first one, historically, healthcare organizations were built to support a fee-for-service model. In the future, value-based care models will dominate. Presently, healthcare organizations are navigating both worlds, fee-for-service and value-based care simultaneously, while healthcare executives try to fully bridge the gap from the fee-for-service past to the value-based care future. This reality directly impacts employed family physician contracts and leads to the often contradictory incentives in those contracts. That being said, the move to value-based care, combined with the growing momentum to invest in primary care and the nationwide shortage of PCPs, means that now is a great time to be a family physician. So again, I've 15 years out of residency. I'm more excited about what the next 5 years look like as a family doc than at any point in the last decade and a half. Again, I think the future is just massively bright for this specialty, especially if we totally understand how we fit into this future state and can advocate for that value for ourselves and for family medicine as a whole. So as a reminder, Module 4, before we get into the Q&A, we're going to take a little summer hiatus. So we've been meeting once a month kind of through the spring. Module 4 is going to be similar to this one, but it's taking the perspective of insurance executives, so payer executives, how they see the world, and then how they try to influence patient care and physician behavior and such. That'll take place several months down the road. So that'll be Tuesday, September 18th, again at 6:30 p.m. And that says Module 4, but that actually will be Module 5. Forgive me for the typo there. And then we'll wrap it up in October with a final session. And that final session is really about pulling all of this together and figuring out what does it mean with this knowledge to more effectively navigate our way through the system. So how do we advocate for change? How do we advocate for our patients? How do we continue to advocate for ourselves and our professional satisfaction and professional fulfillment? And so it's going to be pulling kind of components of all these different lectures. A big piece of this is understanding how those in charge of organizations view the world and make decisions. So again, to be effective in implementing change, understanding what the leaders of your organization, how they think, what the challenges they're facing, and then again, also understanding those insurance executives and how they think, that's really key to impacting positive change for yourself and your patients. So